Good afternoon, viewers. On behalf of DocPlexus, I'm Kajal Mukherjee, welcoming you all to these sessions on case-based learning from Motilal Nehru Medical College, Prayagraj.
কি মনে আছে?
Well, sir, this event is the first episode of peer-to-peer learning series called Case-Based Learning from Motilal Nehru Medical College. Inherited reactive perforating collagenosis is a rare genodermatosis characterized by transepidermal elimination of altered collagen. It's typically present in childhood with recurrent itchy papules and nodules that heals with central umbilications and scarring. This condition is often triggered or exacerbated by minor trauma or pruritus, and its chronic relapsing course can significantly impact quality of life. Understanding its clinical features, histopathology, and management option is essential for timely diagnosis and effective patient care. For today's sessions, it's my privilege to introduce chairperson and panelists for this session, Dr. Amit Shekhar, HOD and Associated Professor, Dermatology Department, Motilal Nehru Medical College, Prayagraj, and Dr. Shambhavi Pandey, Junior Resident, Dermatology Department, Motilal Nehru Medical College, will present her case today. So without further delay, I hand over to Dr. Amit Shekhar and requesting to introduce other faculties who are present for today's session. Over to you, sir.
Currently, we have Dr. Shwetalina Pradhan. Ma'am is HOD AIMS Patna, and she is also editor of Indian Journal of Pediatric Dermatology. She has got various research products and publications to her credit, and she is a very good academician. I've also invited other senior faculties to join me since it's a weekend and quite a people will be their clinics are full, so they'll be coming in and they'll be giving their insight, but their stay in the Zoom meet will be limited. So, ma'am, I'd humbly request you to please guide us and tell us if we have missed out on anything. Now, Dr. Shambhavi, I would request you to kindly start with your topic.
Okay. So good afternoon, everyone. Today we'll discuss about this case. A patient, 13-year-old female student of class 5th, resident of Prayagraj, presented with us with chief complaints of multiple thick, raised, itchy lesions on face, bilateral hands, legs, and feet since 4 years, and multiple depressed scars of preceding lesions since 4 years. This is the image of the patient who presented to us. The black arrows shown here signify the papules, and the blue arrows which are shown is showing the depressed scars of the preceding lesions. These are the images of limbs. History of presenting illness. Multiple on and
Show
off
the
thick
images of the
raised
limbs.
lesions were present on face.
Show the images of the limbs.
So these are the images.
Next.
History of presenting illness. Multiple on and off thick raised lesions were present on face, extensor aspect of bilateral forearm, legs, and dorsum of bilateral feet since 4 years. These lesions were of sudden onset and were progressive in nature. Initial lesion was seen on dorsum of right hand, followed by left hand, and subsequently involving leg, feet, and face. Lesions healed in approximately 4 to 6 weeks on its own, forming a thick, hard crust with occasional discharge of white, thick fluid. In span of approximately 1 week, these crusts fell off on their own, leaving behind depressed scars. History of appearance of new lesions at the site of trauma was present. History of severe pruritus during onset of the lesions were present, and family history for similar lesion in elder brother was also present. There was no history of self-inflicting trauma. topical application prior to appearance of lesions, underlying systemic disease, or any other genetic disorder. So we also examined the patient's elder brother. On examination, these lesions were present on his face. Mainly scars were seen. Papular lesions were less. These are of the patient's brother. So both the patients had both the siblings had similar lesions. For examination, parents' consent was taken before examination. Patient was well-oriented, time-place person and was cooperative. Pallor, icterus, clubbing, cyanosis, edema, lymphadenopathy were absent, and systemic examination was within normal limit. On cutaneous examination, multiple, well-defined, hyperpigmented, hyperkeratotic papules with central crusting were present on both the cheeks, dorsum of left hand, left leg, and dorsal aspect of bilateral feet. Multiple, well-defined, depressed, over to circular, and few linear scars of varying size, ranging from pinpoint to 1 by 0.5 centimeter, were present on entire face, sparing nose and chin, extensor aspect of bilateral forearm, hand, and bilateral lower limbs. On palpation, these scars were adherent to underlying tissue, and also the overlying skin was not mobile. This was the dermatoscopic examination. First image, which is a little bit above, is the image when the crust was intact. Here we can only see central keratotic plugging. Second image is after the crust was felt off. So here a peripheral white rim with pink halo was seen. Central crusting with periphery hairpin vessels were visible. So on examination and based on the history, these differential diagnosis came to our mind. First was inherited reactive perforating collagenosis. Second was Kyle's disease, also known as acquired reactive perforating collagenosis. Next was elastosis perforans serpiginosa, perforating folliculitis, prurigo nodularis.
Dr. Amit, can I request you to mute?
Yes, I'm muted.
Yeah, carry on.
So this is the table I have taken from IADVL, which is telling briefly about all the transepidermal disorders. We'll discuss later. First, we'll go through the case investigations that the patient went through. All the investigations, including routine hematological investigations and urine investigations, were within normal limit. Routine blood sugar and thyroid profile was also done to rule out other disorders like elastosis perforans serpiginosa. This was the histopathological image. A 3 punch biopsy was taken from a fresh lesion. So in this is a 10x picture where above the epidermis, we are seeing keratin and basophilic debris. Then we can see orthokeratosis with typical basket weave appearance. Here we can see focal breach in basement membrane, and above it there is trans-elimination of collagen. And below, acanthosis can be appreciated. So, case summary for the presentation. A 13-year-old female presents with 4-year history of multiple hyperkeratotic itchy papules which are primarily affecting the face, hands, and bilaterally the feet. Lesions occasionally discharge a thick white fluid and healed with multiple depressed scars. Her elder brother has a similar history. Routine investigations were within normal limit. Dermatoscopic examination revealed central keratotic plug with peripheral hairpin vessels. Skin biopsy showed transepidermal elimination of collagen. So on the basis of history and examination, the diagnosis was consistent with inherited reactive perforating collagenosis. Patient was managed. First of all, patient and the attendants, that is the guardians, were counseled about the nature and course of the disease. They were told to prevent trauma because this would further exacerbate the disease. Topically, we advise clobetasol with salicylic acid to remove the crust and application of emollients. Systemically, we gave antihistaminic to suppress the pruritus. and retinoids, that is isotretinoin, was started at 0.5 mg per kg per day. Thank you.
Uh, any other modality of treatment that we can use,
So there are
like
various
methotrexate?
modalities of. So methotrexate is usually not preferred in this. Matlab, it is not effective, that effective.
What is so special about this disease?
So it's so special that here basically we see trans elimination of collagen through
No,
the
no, no, no,
epidermis.
no, 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 no. What I mean to say, I'm asking you the question and I'm giving you the answer. This disease is usually seen in patients suffering from kidney disorders and stage renal chronic kidney disorders and stage renal kidney disorders or long standing diabetes. Now, both these patients, they are pediatric patients basically. So this is one peculiarity. And chronic kidney disease, methotrexate should be given with the a little bit of with on guard. But if you search the literature, can we give JAK inhibitors?
So I didn't found anything as such as a biological for treatment modality in this case,
Mhm,
because this is a case of inherited reactive perforating collagenosis, and the
mhm,
other which you told about the diabetes mellitus and end stage renal disease, those are acquired cases.
mhm,
So there we are discussing about inherited ones. So these are not
mhm,
actually associated with end stage renal diseases or diabetes mellitus.
mhm. And did is there any genetics involved?
Dr. Amit, can you just adjust your camera to the center?
My camera is to the center. I'm in the center only.
Uh-huh. No, no. Last time it was you were at the corner of the screen, so that is why. Okay, quite better now. Continue, sir.
Uh, uh. So, what is the genetic manifestation? Some genes are involved. Hello.
So yes, sir. So
Uh,
these inherited cases, these are seen as familial cases, and are very few case reports are there. Specifically, a gene involvement or naming a gene. I don't know the name of the gene.
okay.
I went through the literature. I guess there are 4 to 5 case reports
Mm,
of these
mhm,
inherited cases.
mhm. Sometimes it involves the retina also. Sometimes it involves the literature also. And there are case reports in which we use monoclonal antibodies or gene therapy in especially the not the acquired one, the inherited RPC management. Okay,
Yes, sir.
because in retina it is known as retinitis pigmentosa, and it shows a promising result. And the biologicals approved for this are Luxturna for RPE65 mutation. You can write it down for your future
Yes.
reference. Okay. And you have heard about CRISPR.
Sorry,
What
sir.
is CRISPR? You have heard about CRISPR?
CRISPR gene technology recently that is altering the genetic level.
Yes. So it is at the forefront and it is giving good results. And that's all for the day. I'll make it full screen. That's all for the day, Mr. Kajal. Thanks for
Have
giving us.
sir, we have one or two questions. So
Yes, tell
if
me.
you're able, okay. So the one
Hmm.
question comes like it asking that how can histopathology and dermoscopy assist in diagnosis of inherited RPC?
Tell me, Shambhavi.
How can histopathology and
Histopathologically,
dermoscopy assist in?
First, tell me about dermatoscopy.
in dermatoscopy, basically we see a central. I showed the dermatoscopic image. There was a central crusting, and peripheral hairpin vessels are seen. So, because of trans-elimination of collagen is there, so keratin debris is accumulated. That is seen as the central crust is in dermatoscopy. Now, coming to histopathology, RPC is basically of collagen is seen there. It is a trans elimination disorder. So in biopsy, we see this trans elimination of collagen. Specifically to rule out RPC, we will need special stains like Van Jason to see whether it is collagen or other elastin material. This is something which was missing there. So yes, with Van Jason stain, we can differentiate with other two, the differential diagnosis that I discussed, elastosis perforans aeruginosa. This would stain black, but if it is collagen, it would stain red. So this is the way you can differentiate with, on the basis of histopathology.
Uh, uh, the next question, King, what treatment option, though you have already recommended, but at the cost of repetition also.
And I've also included the latest treatment guidelines.
Okay, okay.
Hmm.
So yeah, so it is already there, sir. What treatment options are currently considered most effective in managing inherited RPC, and how successfully are they in preventing recurrences?
See, recurrences will be there because the defect is at the gene level. So the patient will continue to have RPC. Now, depending upon the severity of the RPC, we can give oral treatment or we can give topical treatment. If it's less, we can give topical treatment, and if it's more, we can give oral treatment. Oral treatment means retinoids, that means vitamin A analogs, or we can go for isotretinoin or isotretinoin also. But isotretinoin should be given with caution in children because in it causes early fusion of the epiphysis. So as far as possible, if the lesion is tolerable, give oral treatment only. Topical treatment only, not oral treatment. Don't the doctors should not jump, the PGs should not jump to oral retinoids because that will cause premature epiphyseal fusion, and that will cause shortening of height. And in the topical management, Dr. Shambhavi has already mentioned we can give topical steroids mixed with plain, or we mix with the salicylic acid in 3% or 6%, depending upon depending upon the severity of the disease. Now, if we give topical steroid, we should make one more thing clear, that the patient should not apply only topical steroids. The patient should apply topical steroid once in the day, and in the at the other time he should apply some emollients or moisturizer. Because if the patient continuously applies steroids, that will cause skin thickening, and it can cause post-inflammatory hypopigmentation or depigmentation. Sometimes, as she has shown the pictures on the face, what we commonly see, what the chola chaps, sorry, I'm using the vernacular language, it causes TSDF, topical steroid dependent facies. So one time, just half a drop of topical steroid on the face on that particular spot, and not rub it. And in the morning, apply moisturizing cream, washing after washing it, and rub it. So that won't cause skin atrophy, and that will cause also the skin to become normalized. And if at all the patient is not responding to that also, instead of jumping to oral retinoids, the topical steroid along with the salicylic acid. We can apply topical steroid. We can apply topical steroids or vitamin D analogs under occlusion. It will be a bit cumbersome to the patient, but the effect of under occlusion is wonderful. The same amount of drug gives 5 times the results.
So thank you very much, sir, for your wonderful clarification. I will take the another question, not the last one, but not the least. So what is the long-term prognosis for patient with inherited RPC? And are there any symptomatic association or complications? Are there any systemic association or complication that clinicians should monitor?
Since the defect is at the gene level, which I had described earlier, the patient will continue to have long-term remissions again and again. So after the patient has reached his or her complete height, and if the patient is male, even if the patient is male or female, that hardly matters. We should give retinoids with caution. Only yesterday I came to know that I had given isotretinoin to a lady, and she said she's okay. She was having acne, and then after 4 days, the husband was telling me that her wife didn't knew that she was pregnant. Then I said, "Oh my God, ask your wife to abort. Otherwise, you will have a misformed baby, and you'll be responsible for that." Why didn't she tell that? So the oral retinoids are not the only solution. Topical retinoids, vitamin D analogs. There are so many things that can be used, and we should always monitor the things that for kidney function test and for type 2 diabetes mellitus, because in some rare cases it has been found that the inherited cases of RPCs can have can turn into systemic diseases, especially involving the kidney, and can lead to type 2 diabetes mellitus.
Thank you very much, sir. And we don't have many more questions. So if you permit us, then we will go for the closing. Is it okay with you, sir?
Yes, it's okay with me.
Okay. So thank you very much, Dr. Shambhavi, for an interesting case presentations. And my sincere thanks to Dr. Amit for his expert inputs. I'm sure that this will help.
Practical inputs.
I'm sure, sir,
like
this will help.
like like quite a lot of people, they give isotretinoids,
Right, sir.
isotretinoin
Mhm,
without considering 12-year child, 13-year-old child. They gave isotretinoin
mhm,
without taking into consideration about the epiphyseal premature epiphyseal fusion.
mhm.
So that is quite thing. Then quite a lot of people, they give topical retinoids or vitamin D analogs without telling the patient that instead of using uh, say, I don't know whether you can see my finger or not. Can you see my finger? With this much cream can be reduced to this much of cream if we use the cream under occlusion. So under occlusion therapy, nowadays, very few institutes and very few PGs or very few doctors, they have got the time. Because the problem is not with us, the problem is with the patients also. The patients already read up everything up on the Google and on the AI, and they just come to test our knowledge.
Dr. Manas Chatterjee
Yeah,
has joined.
Manas Chatterjee, sir has come.
Sir,
Welcome, sir. Please unmute, sir.
Dr. Manas Chatterjee, sir, I'm Kajal
Hello, good
Mukherjee.
afternoon.
Good afternoon.
Good afternoon, sir. Sir, it's a privilege to see you.
Thank you. Thank you.
So
Uh,
in short, Shambhavi, just say the presentation once again. In short, the main findings.
Okay, sir. So I need to run the PPT also?
Yes,
So just tell me verbally बता दीजिए. You can show the
verb,
images of the patient, that's all.
verbally
Okay, sir.
बता दो, images दिखा
Ju-
दो.
Yes, sir, just a second.
Please don't start from thank you.
Yeah.
This is
Okay.
this.
Yeah, you can show me the summary. I think that
So
should be okay.
this,
Yeah, show me the images. Yeah.
the,
Yeah, just go ahead.
this Yes, sir. This was the 13-year-old female that presented to us with chief complaints of multiple itchy lesions, raised lesions on face, dorsum of bilateral extremities since 4 years. And according to her, these lesions healed with crusting, and occasionally there was discharge, whitish discharge. And
Okay.
after these crust felt off, it left these depressed scars, which are shown by blue arrow on her face. The black arrows here show the keratotic papules, and the blue arrows show the depressed scars. On
Got
history
it.
taking and examination, we found that similar complaints were present in his 3-year elder brother. This is the image of her elder brother. On
Okay.
face, no keratotic papules were appreciated, but these depressed scars were there. These are the images of limbs of the brother.
Okay.
So we examined both these patients, and this was the dermatoscopic examination. First image is before the crust has felt, and second image is after the crust was removed. So in second image,
Got it.
peripheral white rim was seen and hairpin
Yeah,
vessels
yeah.
were seen. On the
Yeah, yeah.
basis of
You get what
history
you
and
call a three-layer
examination, these
pattern.
were the different. Yes, sir.
What's the what
On the
what
base,
pattern?
You get a
the
three-ring
three-layer
pattern.
pattern. Yes,
Yeah.
sir.
Three-layer pattern. Okay.
Yeah. Okay.
So on
Okay.
the basis
Fine.
of
Got it.
history, yes, sir.
Go ahead. Go ahead.
On the basis of history and examination, mainly these 5 differential diagnoses came to our mind. First
Okay.
was inherited reactive perforating
Got
collagenosis.
it. Got it. Go ahead. Go ahead. Go ahead.
Okay. Second was Kyle's disease. Third was
Hmm.
elastosis perforans serpiginosa. Fourth
नहीं,
was
got it. Got it.
perforating.
आगे चलो. आगे चलो. I've seen
आगे
that.
आगे
Okay,
चलें.
sir. So we did biopsy for the patient. We took a 3
Yeah.
mm punch from a fresh lesion, and this is the image, histopathological image showing keratinous debris. Typical basket weave orthokeratosis. Breach in focal breach in basement membrane can be appreciated with trans-elimination of collagen. So collagen exactly can't be said on this slide because stains are not used. This is H&E staining. This is the case
Understood.
summary. Yes, sir. So based on examination and histopathology, we concluded that this was the case of inherited reactive perforating
Okay. Yes.
collagenosis.
Yeah. Yeah.
Yes, sir.
Okay. Okay. Chalo, nice. Good case. Good case.
So
Thank you.
any questions you
You
would
have to
like to
plan
ask?
to special stains?
So special stains we use, Van Jayson stain is used, which usually differentiates between elastin fibers and collagen fiber. So collagen will stain red and elastin will stain black. Other content will stain yellow. So it will differentiate and tell exactly which disease it is.
You've done this thing?
No, sir, this was not available at that time,
Okay,
so we haven't
understood.
done that.
Understood. Take. No, nothing. I think this case is generally, yeah, it's sort of more or less clear from the history, the dermoscopy, the clinical examination, and the dermoscopy as well as the histopathology. So it's quite clearly the diagnosis of yours is right. And
Dr.
so how you
Shambhavi, can
planning
you
to manage him?
stop sharing?
How you planning to
Yes.
manage?
Sir, we managed this patient. Uh, First of all, we counsel the patient and the attendant about nature of the disease and also about preventing the trauma, because in history we got the history ki jahan pe bhi they get trauma, they get a new lesion at that site.
Correct.
And then topically we advised for steroid, that is clobetasol with salicylic acid, excluding the facial lesions, and emollient application. Systemically, to suppress pruritus, we advise antihistaminics and retinoids, that is isotretinoin was started at 0.5 mg per kg per day.
Okay. So which retinoid would be a better drug to use here?
Sir, isotretinoin was, we started isotretinoin.
So, do you think acitretin would be a better choice?
Sir, it can be.
Okay,
Sir, I'm not sure.
okay, fine. How is the patient doing after treatment?
Sir, we kept on follow-up. I guess 6 months, after 6 monthly follow-up, the lesions have almost healed. No new lesions were seen, but these depressed scars were present.
So, you've counseled the family, etc.
Yes, sir. The first thing we did was we counseled the family and both the siblings about the nature of disease and for prevention of trauma and excoriating lesions.
Fine. So, do you have any post-treatment follow-up photographs?
Not on the presentation, sir, not yet.
Okay. Chalo, good. Thank you.
Thank you,
Thank you.
sir.
Well done.
Thank you so much, sir, for joining, sir.
Thank you. Actually,
It
I'm
was
going
an,
to
it,
Lady
it
Harding.
was
I have
an,
a lecture there today. In fact, Delhi State Branch ka meeting, I have a talk from 3
uh-huh.
o'clock.
Dr.
I'm
Shambhavi,
rushing
can
there
you
only.
stop presenting so that we can have a discussion with Dr. Chatterjee? Hi, sir. I'm Kajal Mukherjee. I used to meet with you when I was in GlaxoSmithKline Dharma department.
Okay. Thank you.
So I'm in Calcutta. So now I'm in Doc Plexus.
Okay.
Thank you very much for your time, sir, and especially
Thank you.
for your expert inputs, which will encourage the PG student across India.
Thank you so much.
Sir,
Thank
in
you.
Doc Plexus, sir, we always encourage to peer-to-peer learning, and this is one sessions we are doing only for. This is now currently broadcasting live across all the top medical college in India. And once the
Okay.
event will be over, sir, it will remain recorded on the platform for future viewing.
Okay. Thank you. I'm
Yes, sir.
actually going to, they have a Delhi State Branch meeting. So I'm going to, I'm just going to reach Lady Harding Medical College. I have a talk from 3 o'clock. Thank you. Thank you so
Thank you very
much.
much.
Okay. Thank you so much, sir.
Thank you very much.
Thank you. Bye-bye. Thank you.
Thank you, sir.
So, Dr. Amit, we will close with your last comment from your side, sir.
It was an honor to have such good panelists, and it was a privilege to discuss such a rare case with a in with two siblings having the same disease and getting the opportunity. Thank you so much.
Thank you very much, sir. Thanks once again, Dr. Shambhavi, for an interesting case presentation. And my sincere thanks to Dr. Amit, sir, for his expert inputs and for his efforts to make this session successful. I'm sure that this will help SCP and PGs and SR across India to utilize the learning in their day-to-day practice. Those who have missed it, this knowledge field event can see it recorded version on DocPlexus platform on the past event series. So please look forward to DocPlexus platform for more interesting sessions like this. So with this, with permission from Dr. Amit sir, I will closing this. Sir, be there. We will be offline. I will get it. So I will have a small feedback from you. Thank you. So.